Hello everyone, I'm Mohamed Atef from year 2 and I'm proud to present to you along with my colleague Aroosha from year 1 the urinary system. This presentation from PACademia is proudly presented to you, you foundation year students, and to help you with your Bio 2 final exams inshallah. Also special thanks to Shahd for the idea of course and for the annotations. All right, so what will we be learning about today? On my part, I will be describing the structural and functional features of the kidneys, and I will be also stating how what histological characteristics of the nephron are and how they contribute to urine creation. My colleague will be talking to you about kidney function and how the kidney transports, stores, and eliminates urine, and I'll be talking about it a bit as well. So, what are the kidneys? Well, we all know the kidneys, they are very important organs, although they may be a bit underappreciated. They have a very varied or a huge variety of functions, which include but are not limited to regulating body and solute composition, which almost everyone knows about because basic creation of urine. However, there are a lot of other important things as well, like acid-base balance, excreting metabolic wastes, producing red blood cells and regulating blood pressure, activating vitamin D, which is important for calcium homeostasis, and they actually work on gluconeogenesis during fasting. Along with the kidneys, of course, they cannot do their function without the rest of the transport system, which includes the ureters, the urinary bladder, and the urethra. Going more into the gross anatomy of the kidney, we all know they are bean-shaped organs. We should know also that they are retroperitoneal structures, which basically means they are behind the peritoneum, which is like a plastic bag sac-like structure that encloses abdominal organs with several compartments. They are behind that peritoneum. They span from the vertebral levels of T12 to L3, and they are medially concave. They also include the hilum. Each kidney has a hilum, and this hilum has the ureter, the renal vessels, lymphatics, and nerves. They are also bounded superiorly by the adrenal glands or the suprarenal glands, which produce a variety of hormones, which were discussed in the endocrine system. They are covered by several layers, which include a fibrous capsule, and that fibrous capsule is bounded by some perirenal or perinephric fat, which is all together covered by renal fascia. And the fascia is considered of dense connective tissue, along with fibrous capsule as well. One of the important things about the kidney, especially in terms of homeostatic imbalance, is pyelonephritis, which is basically it's just inflammation or infection of the kidney, inflammation of the kidney to be exact, and the infection might cause it. So it's important to know that it's especially common in females because of the close proximity of the urethra to the anal canal, and that could allow some of the GI bacteria to go into the urethra and ascend upwards and then eventually go to infect the kidney. This may cause, in severe cases, for abscess formation and pus accumulation, and we usually treat it by antibiotics. Now for the not so fun part, but I promise inshallah it will be easy. The kidneys have a strong neurovascular supply, partly because, of course, they take up to 1/4 or 25% of the cardiac output, which is a huge amount. But that's important because they are filtering blood. Okay, without them, we will have a lot of toxic materials in the blood, and homeostatic imbalance would go awry. So, what happens is basically there is a network of vessels, and they start with the right or left renal arteries, the right being longer, of course, because the abdominal aorta, which brings out the renal arteries, is situated more to the left. So what happens is the renal artery to the right kidney or to the left kidney goes out from the aorta. The aorta brings out the renal artery, and then the renal artery separates into five segmental arteries, okay? And then these five segmental arteries further go into, let me show you here. So basically here you have the renal artery, divides into segmental arteries, supplying various segments of the kidney. And these segmental arteries, when they enter um, into the renal columns here, they become interlobar arteries between the pyramids of the kidneys. And then following that, they become arcuate arteries at the base of the pyramid, so above here as shown by the laser. And then eventually they bring out cortical radiate arteries. So these are the ones that go here, or called interlobular arteries, which spread into the cortex to provide blood to the glomeruli, and which we will be discussing. Following that, the cortical arteries brings out afferent arterioles, which supply the glomeruli, and then come out as efferent arterioles, which is important to know because usually we think of a blood supply as arteriole, then capillary, then venule. Here we have arteriole, then glomerular capillary, and then arteriole again, which is efferent arteriole. And this efferent arteriole has a lower pressure, has basically lower pressure compared to the afferent arteriole, but we will get into it. These afferent arterioles then give out branches to vasa recta, which we will discuss as well, or peritubular capillaries, which eventually drain into cortical radiate veins, then arcuate veins, and then not segmental veins. There are no segmental veins. It's specifically exactly right away into interlobar veins, then the renal vein, with the left renal vein being longer, because the inferior vena cava, which finally the renal vein drains into, is more situated to the right. And in terms of the nervous supply, the kidneys are supplied by the renal plexus, which comes out of the pelvic of the celiac plexus. Again, not really that huge of a thing, but they eventually regulate different the vasoconstriction of the vessels in order to regulate pressure and glomerular filtration rate, which again we will get into it. So now into the a bit of a confusing part, which is nephrons. So nephrons are the main histological or the basic unit of the kidney, okay? And they are basically these structures. They are the basic functional unit of the kidney. What they do is they filter blood and they reabsorb some materials from that filtrate and secrete some materials into it to eventually create the final urine. They consist of a renal corpuscle, which are, wait a second, let me show to you. Yes, these are the renal corpuscles here. And then you have the renal tubules. And eventually these tubules will drain into the collecting duct, which go to the renal pelvis and drain out of the body as urine through the collecting system. So what is the corpuscle made of? Well, you have the corpuscle here, and it is made of a glomerulus and a glomerular capsule, also known as a Bowman's capsule. So the glomerulus is basically a tuft of capillaries, and it contains fenestrated capillaries, and they are very high pressure. So because they are fenestrated and have a high pressure, they allow for the filtration of blood. So the blood goes through them, and then a lot of water and a lot of solutes go out, and practically only some proteins are left. Most proteins don't pass through it, but the majority of solutes and water do. So what happens is, following this filtration of blood, the filtration of the filtrate, or the formation of the filtrate, this filtrate collects in the Bowman's capsule or the glomerular capsule, which consists of a simple squamous parietal layer, which is not that important in terms of functionality, aside from forming the outer layer. However, we have a very specialized visceral or inner layer, which are the podocytes shown here. And these podocytes hug around these capillary walls or the basement membrane of the capillary walls, the glomerular capillary walls. And these podocytes have things known as food processes. So they have these multiple foods. That's why they're called podocytes, pod for food. They have these foot processes or pedicles, and between the foot processes there are small spaces called filtration slits, and they allow for optimized filtration of the blood without getting rid of proteins. That's basically the most of what you need to know. Following that, the blood or the filtrate, now it's called the filtrate, goes into the proximal convoluted tubule, which is part of the renal tubules. So what happens is this proximal convoluted tubule is also a bit specialized because it functions in a lot of reabsorption. So it's made out of cuboidal epithelium, and some histological characteristics here include having a lot of mitochondria, which makes it eosinophilic, and they have a lot of apical microvilli, so they form like a brush border, similar to the GIT, but for a different function, of course, basically to increase surface area for reabsorption. So it's similar function actually, and they are in the cortex, the renal cortex. Then we have the loop of Henle or the nephron loop, which consists of the descending limb formed of simple squamous cells, and then the thin ascending limb and the thick ascending limb, or sometimes one ascending limb. But generally, the thin ascending limb is also simple squamous because thin, you can think about it as simple squamous, and the thick ascending limb is low columnar or cuboidal and may go into the medulla. This loop of Henle may go into the medulla in things known as juxtamedullary or corticomedullary actually nephrons, which we'll get to, or juxtamedullary nephrons, my bad. And then finally we have the distal convoluted tubule, which is made of cuboidal cells, and they are found in the renal cortex, and finally they drain into the collecting ducts and the collecting system. Again, this is pretty much what I have mentioned in the previous slide. You can pause and go through it if you would like. So, continuing with the nephron, we would like to eventually end up with the collecting duct. So, what happens is these collecting ducts are the final part of the nephron, the most distal part of the nephron, which eventually connects to the, here as shown here, the minor calyx, then the major calyx, which are anatomical features now. They are big enough to be seen by the eye. Then we have the renal pelvis, and then we have the ureter, which eventually runs into the urinary bladder, and then the urethra, and then finally the toilet. So what happens is this collecting duct of the nephron, going back to it, has two main types of cells which are very important in solute homeostasis. So we have principal cells which have short and few microvilli, and they are important for sodium and water balance. So salt and water balance basically. And then we have intercalated cells, and these intercalated cells, there are type A and type B, and they work in acidosis and alkalosis. So they function to maintain acid-base balance, and they are consisting of cuboidal cells with a lot of microvilli. It's important to know that there is this hormone you may have heard of called antidiuretic or hormone or vasopressin, and it acts in the collecting duct and the distal convoluted tubule as well, in order to allow for water reabsorption. So what happens is it's called antidiuretic hormone. So it prevents the diuresis or the loss of water in the urine. So what happens is, or urine, not urination specifically. So what happens is the water is absorbed from the urine, allowing the urine to be more concentrated due to ADH. This ADH allows for the deposition of several channels called aquaporins, which allow for water to move from the kidney into from the collecting system or from the tubules here and the duct into the blood again. These ducts collect the filtrate which is becoming the urine now from a lot of nephrons, not from a single nephron, and they pass through the renal pyramid eventually to fuse into the minor calyx, which again follow this until they drain outside the body. We have two main types of nephrons, it's important to know. So we have cortical nephrons, which are mainly in the cortex, and they're the majority, about 80% or 85% of nephrons. And then we have juxtamedullary nephrons. So cortical nephrons have a short nephron loop and they originate away from the medulla, so towards the surface of the kidney. And it's important to know that efferent arterioles bring out peritubular capillaries from them, while in juxtamedullary nephrons, efferent arterioles bring out or drain into vessels known as vasa recta. So what do these vasa recta do? Well, in order to know, let's know what the juxtamedullary nephron do and how they are different from the cortical nephrons. So the juxtamedullary nephrons, what they do is basically, first of all, they are originating near the medulla, so in the cortex near the medulla, and they have a long loop of Henle or nephron loop, which goes down into the medulla into the renal pyramids. And what happens is these long loops, as shown here, they have a lot of vessels surrounding them, which are the vasa recta, which come out from the efferent arterioles. And these vasa recta allow to maintain a concentration gradient, basically, which causes the concentration of urine. So why are juxtamedullary nephrons important, even though they form like 15% of nephrons only? Because they are very important in concentrating urine. Again, we have three main types of nephron capillaries, just to wrap it up. We have the glomerulus, which is the tuft of capillaries which allow for filtration, and they are fed by the afferent arterioles and drained by the efferent arterioles, and they have a very high pressure and are parallelly arranged, which helps in their function. Then we have the peritubular, which come out in the cortical nephrons from the efferent arterioles. They have a low pressure and low diameter, and because usually pressure and resistance are inversely proportional, they have a high resistance. They allow for absorption of water and solutes, and they arise from the efferent arterioles and drain into venules. Finally, we have the vasa recta, and we previously mentioned them. Vasa recta, recta means straight, vasa means vessel, so they are straight vessels. And they not only they say supply blood and nutrients to the loop of Henle, but they also maintain the osmotic gradient that allows for the concentration of urine. Following that, we have a structure known as the juxtaglomerular complex. So what is this GJC basically? Well, um, it is a formation of multiple structures actually. So it's formed of three main things. First of all, there are the afferent arteriole, and then there is the distal ascending limb. So there is two main things actually, the ascending limb and the afferent arterioles. And there is sometimes the efferent arterioles as well, but mainly these two. When the afferent arterioles and the distal ascending limb are close to each other, they have some specialized cells which come in contact to help in a variety of functions. So let's start with the ascending limb cells. So what happens in the ascending limb, when it's close to this juxtaglomerular complex or juxtaglomerular apparatus, they form cells known as macula densa cells. And these macula densa cells of the ascending limb of the loop of Henle are in close contact with the afferent arterioles. What these macula densa cells do is basically they monitor the salt content in the distal convoluted tubule. So as the ascending limb continues as the distal convoluted tubule, these macula densa cells, they are monitor the amount of NaCl in entering these distal convoluted tubules. So they are considered chemoreceptors basically. And in terms of structure, they are tall and closely packed. Next up, we have the afferent arterioles, which have the specialized cells known as granular or juxtaglomerular cells. These cells, unlike the macula densa cells, which are chemoreceptors, the juxtaglomerular cells are considered mechanoreceptors. And what they do is basically they sense the blood pressure in the afferent arteriolar walls, okay? And they contain granules having a hormone known as renin, which you might have remembered from the endocrine unit with the renin-angiotensin aldosterone system, okay? Yes. So finally, we have a third type of cells, which is not really considered part of the juxtaglomerular apparatus or complex, but it's again worth mentioning. It's called the mesangial or extraglomerular cells. And basically they form the stroma or the supporting structures around the arterioles and the tubular cells. And they are also found inside the glomerulus, but again, you will talk about that in more in year 2 actually. These mesangial cells are connected by gap junctions, and they pass the signals between the macula densa cells and the juxtaglomerular or granular cells. And finally, we come to the important thing, which is urine formation. All of it is important, of course, but that's particularly important because that's the main function. So, in order to know how urine forms, we need to know what urine is. So, we need to differentiate between something known as the filtrate and the urine. The filtrate is all the plasma except for some proteins. So, the filtrate is basically what comes out of the glomerular or glomerulus or the capillary tuft of the glomerulus. It contains almost all solutes and water except for the proteins which do not pass due to the podocytes. But again, no need to get into this. And while going through the renal tubule, so the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, and sometimes in the collecting duct and in the collecting duct as well, this filtrate is modified to eventually form the end product, which is urine, which is everything unneeded that needs to be excreted. Okay? So the filtrate gets processed via selective reabsorption and secretion to eventually form the urine. And this urine formation is based on three main steps. So first of all, we have glomerular filtration, which happens in the renal corpuscle with the glomerulus, and it's non-selective. So if almost all fluid and solutes get out, okay? And it's passive. So because of the high pressure, they get out into the renal tubular system, into the Bowman's capsule first, then the renal tubules. And this filtrate has no cells and no proteins. That's really important to know. If there are cells and proteins in the urine, we know that there is a pathology, okay? Generally, يعني, generally speaking. Then we have a tubular reabsorption. And what happens is it's mainly in the proximal convoluted tubule, actually, but it happens along all the tubules. It's selective. So there are specific channels and ducts which allow for the movement of specific solutes, so sodium and other solutes, into the blood. And there is also secretion. So what happens is we don't need some things in the blood that have not been filtrated. We excrete them or secrete them into the tubules, and then they become excreted in the urine. And it's important to know that since glucose is not a cell or protein, it actually also gets filtrated. So it gets out into the urine or into the filtrate, but it's eventually reabsorbed. Okay, again, we reabsorb it again. So if there is glucose in the blood, you know that there is a or in the urine, I mean, then you know there is a pathology. And with that said, we now move on to my colleague Aroosha, who will be discussing the remaining of the unit. Thank you so much for listening to me. Please keep praying for our brothers and sisters in Gaza, in Sudan, in Yemen, in Syria, and everywhere, wherever people need help. Keep praying for the finals. Pray for us because we are having a tough time too. I hope you really enjoy this video and find it helpful, and I hope future people find it helpful as well. Thank you so much for listening and best of luck, my friends. Assalamu alaikum wa rahmatullahi wa barakatuh. Now moving on to Arusha.
Hello everyone, my name is Aroosha and I'll be continuing the urinary chapter. So my part involves 25.8 and 25.9 as well as the developmental aspect. So let's start. Okay, so to begin with, I have renal clearance. What exactly would renal clearance mean? From the name itself, it would basically be a measure of how well your kidneys are able to clean your blood, right? So this is renal clearance. Just break down the words and you're gonna get the answer. Okay, so before I start this part, I wanna mention that this was not really important for us last year and it was cancelled, but I'm gonna go over it just in case you guys are going to be tested on it. Okay, so like I told you, renal clearance is basically your kidney's ability to clean the blood. Now let's see the formula for renal clearance. It's basically clearance equals to UV. Okay, what's U? U is going to be my urine concentration, so it's going to be the urine concentration. And what's V? V is going to be the urine flow rate, so it's going to be the urine flow rate. Okay, now what's P? So the urine concentration and the urine flow rate over the plasma concentration, So in this case, you should be able to basically understand the formula, because they're not really going to give you any numbers like, oh, can you do the calculation? But you should be able to tell, okay, if for example the urine flow rate is high, then the renal clearance would be high. Okay, if the urine concentration is low, then the renal clearance is going to be low. So this is directly proportional, whereas the renal clearance and the concentration, the plasma concentration, so P stands for plasma concentration of the substance, are going to be inversely proportional. So if this increases, this would decrease, and the opposite effect over here. So if this increases, this would increase. Okay, so try to understand the relationship, and it kind of makes sense, right? So if you're going to increase the urine flow rate, if the flow rate would be high, the clearance would be high, correct? Okay. Now, okay, so when we have renal clearance, we basically compare it to a substance called inulin. Now, inulin is like a reference substance that we're going to use. Okay, not really important, but let's look at what happens if the substance clearance is higher than inulin. In this case, you can basically you can tell that the kidneys are removing the substance better than the substance inulin. Okay, so the substance that the kidney has, which we're comparing to inulin, is being removed at a better rate than inulin. Okay, now the next thing is if it's lower than inulin. So by logic, it indicates that the kidneys are not being able to remove that substance as efficiently as they would with inulin. Okay. And then I have equal to inulin. This basically would suggest that the substance is being filtered by the kidneys very similar to inulin, which is basically a good indicator of the function of the kidneys, right? Okay, so this is the basic idea over here. Okay, now let's talk about two important conditions: chronic renal failure and renal failure. Okay, so what's chronic renal failure? In chronic renal failure, okay, in these two conditions, what's really important from you guys is to basically understand what's happening over here and how can you differentiate the two and what are the key features over here. Okay, let's go over them together. So in chronic renal failure, what are you going to have? The GFR, which is the glomerular filtration rate. Okay, it's going to be what? It's going to be low. Renal failure, so of course it's going to be low. But in this case, you don't really have to know the exact number, but I would suggest that you know it so that you can compare between the two. Okay, so when we come to that, we're going to see. In this case, the glomerular filtration rate is going to be less than 60 ml per minute. Okay, and this occurs for at least 3 months. Okay, so like I said, it's chronic, so it's going to be for at least 3 months. Okay, now it's going to often be developing very silently as in like you will not be able to tell that a person has this because they will not, or they might be asymptomatic. Okay, now in this case, so like I said, first thing is first, that the glomerular filtration rate is going to decrease. What are other things that are going to happen? Okay, so nitrogenous waste will accumulate. Where would it accumulate? In the blood. So this is the blood. So nitrogenous waste would accumulate in this region. And what happens to the pH? In this case, the pH is basically going to become more acidic. It's going to become more acidic. I'm not sure why it's not here, but let's write that down, that the pH is going to become more acidic. So pH would go more on the acidic side in what? In the glomerular in the chronic renal failure, which makes sense, right? Okay, now basically there would be leading causes for chronic renal failure. Some of them would include diabetes mellitus to be more specific, and then a person could have hypertension. So hypertension can basically like let's just try to understand, right? So hypertension, which is increase in blood pressure, right? So this can actually this can impair the renal function, right? And this can lead to lower glomerular filtration rate and lower urine, right? Okay. So also other things that we have are heavy metal poisoning, trauma, infection, etc. Okay, now let's move on to renal failure. Okay, renal failure is basically going to be a glomerular filtration rate of less than 15 ml per minute. So this was still okay. But in this case, this has decreased to a level that is very, very low. Okay. So in this case, you're going to show signs of fatigue, anorexia. Anorexia is basically not being able to eat properly. Okay, so these are the signs that a person would present with. And apart from this, you would also have, for example, some mental changes and etc. Okay, now let's look at the features. So in this case, you're going to have something called uremia. Uremia, let's break the word down. So uremia, basically, emia would mean inside the blood, and uremia would basically be urine. So it just means urine inside the blood. In this case, what did I have inside the blood? I had a high amount of nitrogen waste, right? And in this case, what do I have inside the blood? I have a high amount of, or basically a high amount of urine, right? So uremia. Now, these things are what would lead to, for example, some characteristic symptoms like fatigue and muscle cramps and mental changes. Okay, now moving on, there would be other things. For example, there can be hormonal imbalances in this case, and there would be ionic imbalances. So in renal failure, you're going to see all of these things happening in your patient. Okay. Is there a treatment for renal failure? Okay, a person has renal failure, and yes, they're not able to get out as much urine as a normal person. But is there a treatment for this? Yes, so we call it hemodialysis, which I think many of you do know about. It literally just means artificial kidney. So the process of hemodialysis, just to make it very, very simple for you guys, okay. So the process would mean that you have a special machine, and what you're going to do is the blood is going to go through this special machine, and it's basically going to be called a artificial kidney. So it's an artificial kidney that is for the patient. So you're going to take the blood, you're going to pass it through this artificial kidney. Okay, what's special about this? Basically, the blood is going to flow through tiny tubules. Okay, it's going to flow through tiny tubes basically, and these are going to be only allowing certain things to pass through them. Okay, so what would be these certain things? These certain things are going to be useful things, like for example, if you have a malnourished patient, so you would definitely add glucose, right? You would allow glucose to go into their body, so you can actually like kind of tailor it to the patient's needs. But like in general, what would be like useful things that I would want to put inside my patient's blood? For example, H positive, right? These are buffers, etc. And what would I not want to go inside the patient's blood? Bad things like extra ions or waste products. Like for example, nitrogenous waste. Would you want that to go inside the blood? No. So you're basically able to filter it out through the process of hemodialysis. Okay, so it's kind of perfect. And good stuff like chemicals and helpful chemicals are going to go inside. And this would basically mean that the blood becomes more cleaner and healthier, and you can use it to actually solve this problem. Okay, let's continue. So next part is a really, really easy part. Everyone would probably know this part, but let's go over it just to be sure. Okay, so what's urine? Urine is going to be composed of 95% of urine is going to be what? Everyone would know this, right? It's going to be water, H2O. 95% of it is going to be water, and there are going to be some waste products along with this, okay? So there will be some waste products and a small amount of dissolved substances. Now let's look at the chemical composition of urine, okay? So the chemical composition is going to have water. Like I said, it's going to be the major component, so 95% of this is going to be water. Next is urea. Now what's urea? Urea is basically a waste product, okay? Urea is going to be a waste product that is formed by the breakdown of proteins. Okay, just for your knowledge, let's try to understand what are these things, right? So what's creatine? Now creatine is going to be a waste product that's from the muscle metabolism. Uric acid is basically another waste product of other compounds. Okay, now let's look at electrolytes. Electrolytes are basically, for example, you're going to have your sodium, you're going to have potassium, you're going to have chloride, you're going to have bicarbonate, right? So these are going to be electrolytes. And other substances, what other things you might have in the urine? So you might have, for example, certain hormones, or you might have you might have certain enzymes, etc. So this is just to get the basic idea, right? This is the chemical composition. Okay, now for the physical characteristics of urine. So the color of urine is going to be what? It's going to be yellow, but of course the color of urine can vary. It can differentiate, right? Depending on, for example, the foods that you take in, or also, for example, there would be like the general color would be pale yellow to a deep yellow. And this color is because of a agent, okay? So it's called urochrome. Okay, urochrome. Urochrome is what gives this urine its pale or deep yellow color. It's basically a pigment which would result in the which basically results when the body is going to destroy what it's going to destroy, hemoglobin, right? So when you destroy hemoglobin, you're going to get uroglobin, and I think this was mentioned in the blood chapter. Sorry, not uroglobin, urochrome. Okay, you're going to get urochrome, and this urochrome is going to give urine its characteristic color. Now looking at the odor, generally urine should be odorless, but again, eating certain things would definitely alter the odor or the smell. Basically, odor means smell, right? So the smell of urine. Sometimes you might see that some patients, like when they come, like when you take the test, the urine test, you're going to see that the fresh urine is going to smell aromatic, and sometimes, like for example in diabetes mellitus, it's a certain condition in which the urine has a characteristic smell where it basically smells like fruity, okay, because of the high acetone. So this high acetone makes the urine smell like a fruity scent. Okay, now moving on, abnormal urine composition. I cannot stress enough the importance of this table. Literally 5 stars over here. Understand and memorize, okay? So first understand and then memorize, okay? Basically, this table is present on your in your textbook, and to go over it, I'm just gonna do like a brief, just go over it briefly. So if you have glucose, what would the condition be? From the name itself, glucoseuria, right? And this would be common in diabetes mellitus. Diabetes, glucose, right? Okay, proteins, from the name itself, proteinuria or albuminuria. You guys remember the function of albumin? Yes. Okay, so albumin was the protein, right? So in this case, this would occur, for example, in excessive physical exertion or pregnancy. Why would it be in pregnancy? Like, for example, like, use logic to try to explain things, right? So if you have pregnancy, what would happen to the for example, the kidneys? Their pressure would increase, right? And hormonal changes would occur. So all of this is going to contribute to the proteins, right? And this is why you might have proteinuria. Okay, now also, like, same thing, not same thing, but like you can even rule out something for exercise. Like if you're going to have exercise, you're going to have muscle breakdown, and what would that be? That would release or that would result in increased protein metabolism, right? And at the end of the day, you have proteinuria. Severe hypertension. Hypertension is increase in the blood pressure. Remember what albumin does. All of these things are related to each other. Ketone bodies. So the substance itself is going to give you a clue about the condition. Ketone bodies, ketonuria. And this would occur, for example, in diabetes and starvation. Starvation is an important condition that has ketonuria. Okay, then we have hemoglobinuria. There would be, for example, because of transfusion reactions, hemolytic anemia. Even severe burns would lead to this because, for example, in burns, you release stress hormones, right? So stress hormones would result in the production of RBCs to deliver more oxygen, etc., etc., and that would lead to hemoglobinuria. So everything over here, causes, are going to have a logical explanation if you think about it. So this way you're going to understand the table and you're going to be able to memorize it. Okay, bile pigments, bilirubinuria, so easy. The name suggests the condition. This would be associated bile, bilirubin, so liver disease, hepatitis, cirrhosis, all of the, or basically obstruction of the bile ducts. Again, relates to the blood chapter, so to make it easier. Erythrocytes, hematouria, okay? Erythrocytes is going to be hematuria, not hemoglobinuria. So make sure that you guys are not confusing these 2 points together. Hemoglobinuria would be HB and erythrocytes is hematouria. Okay, hematouria could be because of bleeding urinary tract disorders like trauma or neoplasm as in like tumor infections. Okay, and the last thing we have is leukocytes. Pyuria. So I think leukocytes and erythrocytes are the only 2 things where you might, not even erythrocytes, but leukocytes, maybe you might find a difficulty in looking at the condition from the substance itself, but the rest are pretty much straightforward, right? So in leukocytes, they might increase because of urinary tract infection, leukocytes. Okay, now let's actually look at some structures, right? So ureters. Ureters are going to be, let's first look at the function, then we're going to identify where they are. Because in anatomy and physiology, you have to look at the function, and the function itself is going, or basically the structure itself would tell you the function, right? So, okay, so what's the purpose of ureters? They would transport urine from the kidneys to the bladder. Okay, so what do you think the ureters would look like? They are basically connecting the kidney to the bladder, right? Okay, let's look at them over here. This is a really simplified diagram, but you can see the kidneys. You see the ureters is a connection point and a bladder. Now, what's the thing that you have to remember? You have 2. So there are 2 kidneys, 2 ureters connecting to the bladder. Okay. Now, for the ureters, like for example, if you want to describe them, you would say that they are slender tubes, right? They are slender tubes that basically attach kidney to the bladder, like I said, and they are going to be continuous with the renal pelvis. Okay? Okay. Now, before I begin or go into details, I'd like to tell you that, look, for the renal chapter, as for our batch at least, you don't really have to go into depths. This is foundation. You have to understand and you have to get the major or the bulk of the idea. Okay, you don't have to go into very specific details that are mentioned, but you need to understand what's this organ, what's its basic function, what are differentiating features, and what can I understand about its structure. Okay, let's move on. So looking at the histology, let's look at this part and try to understand it. Okay, so I'm looking at my ureter under a microscope, okay, a cross-section. Cross-section means that if this is the person, so I took it like this. Okay, so let's look at it now. So let's start with the mucosa layer, okay, which is this layer on the inside. So this layer is my mucosa layer. The mucosa layer is going to have transitional epithelium and lamina propria. Now, to understand why does the mucosa layer have transitional epithelium? So that it can stretch, right? Remember the function? Stretch, right? So it has this mucosa, has the transitional epithelium, so it's able to stretch. This ureter area is able to stretch. Do you guys remember the function of ureters? It was to carry the urine. So of course you would want it to stretch, right? And so it would stretch and it would accumulate more urine volume. Correct? So the function relates to the structure. Okay, next layer is going to be the muscular layer. The muscular layer is going to have a longitudinal layer, which is on the outside, and a circular layer. The longitudinal layer is going to be here on the inside, and then surrounding it, I can see the circular layer. Okay, so the muscular layer is basically going to contract. Because it's a muscle, it's going to contract, right? So when it contracts, what would it do? It's going to propel urine. So the contractions would be able to contract and propel urine. So this is why everything that we have has its function, right? So it propels urine where? From the kidneys to the bladder. Correct. Okay, so this is through a series of contractions, which would be known as peristalsis. Okay, which would be known as peristalsis. This is an important word, a vocabulary word. Vocabulary. Okay, let's move on. So now I'm looking at the adventia. Okay, so the adventia layer is basically going to be a outer fibrous layer, and it's going to provide protection. Okay, now what do we have? Okay, so the ureters are going to have both sympathetic and parasympathetic innervation. Just remember this part, which kind of makes sense, right? Okay, so let's do a homeostatic imbalance, which is about renal caliculi. Okay, the spelling over here is wrong, but basically I have renal calculi. Okay, so let's discuss the main features. Like I told you, we want to know what's happening. What are the main features? What are the types of renal calculi? Okay, so the types would be, okay, first let's just say what is renal caliculi. It's basically formed because of calcium, okay? Calcium, magnesium salts, or uric acid. These things are going to contribute to renal calculi, okay? And what would it cause? Calculi basically means stones, guys. Okay, so what would it cause? It would cause excruciating or very sharp pain when you're trying to urinate. Okay, now what are the types of renal calculi? So the first type that I have is called I think the spelling is correct, lithiasis. Okay, and the second type is called ureterolithiasis. Okay, I think the spelling is correct. Anyways, okay, so from the name itself, nephrolithiasis, okay, so nephro means kidney, so this would refer to what? This would refer to kidney stones, right? So this would mean kidney stones from the name itself, right, guys? And ureterolithiasis would mean stones. Where? Stones in the ureter. Why did I say this? Because from the name itself, ureter, so ureters and stones. Okay, so what would be the treatment of this? Okay, so to treat this, look, if you have small stones, would you perform a very big surgery just to remove them? No, you just let them be, and when the time comes, they would pass out naturally, right? They would pass out naturally in your urine. Okay, larger ones, however, would you let them be over there and just basically obstruct the urine and cause so much problem? No, you would need endoscopic or surgical removal for those cases, right? And there's a keyword over here that I want to say, which is basically called okay, so it's called lithotripsy. Okay, so sometimes you perform lithotripsy. Lithotripsy, I think you've heard of it in EMS. Lithotripsy is basically going to break down stones, right? It's going to be able to break down the stones by using something called acoustic waves. Okay? Okay, so let's just discuss quickly the risk factors and prevention. Risk factors for renal calculi or stones would be, for example, obesity, or like I said before, renal calculi would be caused because of what? Because of accumulation of calcium, right? Sometimes they're formed from calcium. So if you're going to have a high blood calcium level, you're going to be at an increased risk for these stones, right? Okay. And the next thing is prevention. How would you prevent them? You would try to stay hydrated as much as possible, right? Okay, let's do the urinary bladder now. Okay, urinary bladder, let's think of the urinary bladder as a balloon. Okay, it even looks like a balloon, to be honest, to me. Okay, so it looks like a balloon and it kind of acts like a balloon. How? Okay, so if I were to give a very easy definition to the urinary bladder, or basically if your book was able to give it, it can be described as collapsible and a muscular sac. Okay, so it would be a sac, just like a balloon, and it's collapsible. Okay, so what does this indicate? It indicates that the urinary bladder is not a permanent solution to store urine. It's just a temporary solution. So it's just going to be present as a temporary solution, right, to store the urine. Okay, so this just describes the urinary bladder in like easy terms. Now let's try to understand the urinary bladder more. Okay, so first of all, if you look at the urinary bladder, the first thing that you're going to notice is this over here. Okay, this area, we call it a trigone. A trigone is an area, okay, in the urinary bladder that is basically formed, or it's bounded by two urethral openings. So remember the ureters, they come from where? They come from the kidneys, and they would drain into the urinary bladder. So do you see over here, when they go into the urinary bladder, this part is the basically this part, okay? So this is the upper part of the trigone. So it's the urethral openings, the two urethral openings, and then you're going to have the entrance of the urethra. Urethra is the structure over here, which we're going to come to in about like in some time. Okay, so anyways, this is the trigone, which is a triangular area. Okay, one thing to know about the urinary bladder's location in the body would be that it's going to be retroperitoneal. From the name itself, retro means behind, right? And peritoneal, behind the peritoneal area. Okay, so it's going to be present in this area. Okay, now let's look at the wall of the urinary bladder. Okay, so for the wall of the urinary bladder, what would it be formed of? It's going to have a mucosa. Mucosa is going to be the layer that's going to have the transitional epithelium, right? Again, what was the function of transitional epithelium? It's going to be able to stretch. So the stretching is going to be able to, accumulate or basically accommodate its function, which is to store the urine. And like I said, it's collapsible, right? Okay, so this is going to be the first thing. Then the next thing I have is muscular layer. We're going to mention the muscular layer in a minute, but it's basically the detrusor muscle. Okay, so it's going to be the detrusor muscle. Okay, this is the muscular layer. Next thing I have is going to be, this is a smooth muscle, by the way, of course. This is the detrusor muscle. The next thing I have is basically the adventia, which we even discussed in the ureters. Okay, basically the walls are going to be, as you can see, the walls are going to be thick, and they're going to be folded, right? And the bladder can expand significantly. Like I said, its function is going to be to able to expand, and basically without okay, this is my bladder, it will expand. This expansion is not going to result in an increase in the internal pressure, because if that's what's going to happen, it would not really be able to perform its function, right? So the transitional epithelium will allow the expansion without really increasing the internal pressure so much that it causes an issue. Okay, now let's move on. So let's look at the layers again. Like I said, the muscular layer is going to be composed of 3 layers in itself. The 3 layers are going to be the inner longitudinal layer, the circular layer, and the outer longitudinal layer. These are all going to form an important muscle called the detrusor muscle. Important for the exam. Okay, the detrusor muscle. Okay. Now, let's look at the comparison, because we don't want to be confused. In the ureter, when I talked about the histology of the ureter, I went over MMA. Oops. Okay, I went over MMA. Remember, the mucosa, and then I talked about the muscular area, and I talked about the adventia. So remember here, let's go down. Okay, I have this diagram over here of the ureter and the urinary bladder. This is going to be able to help you to differentiate the different layers, because we don't want to mix them up, right? So in the ureter, remember, the first thing was the transitional epithelium, which was part of the mucosa as well, right, after the lumen. Over here, you also have your transitional epithelium, which makes sense because our function is to hold the urine. And to hold the urine, these organs need to be able to extend, right? Okay, next thing we have over here is the muscular layer. The muscular layer here is composed of two things: the inner longitudinal muscle layer and the outer circular muscle layer. Okay, over here, the muscular layer, first of all, has a name. It's called the detrusor layer in the urinary bladder, and it's composed of the inner longitudinal muscle and then the central circular muscle layer, and then I have the outer longitudinal layer. And the last thing I have in both of them is going to be my adventia or adventia. Okay, so these are the things that I have. Now, these are going to be able to so you have to understand the differences, right? You have to understand how the layers are going to be different. If they ask you circular muscle layer, we're not talking about the ureter, we're talking about the urinary bladder. So make sure that you understand this. Okay, now, when I talked about the adventia, I said that it's present in both of them. But we need to understand that in the urinary bladder, the adventia is not going to be present on the superior surface. Why? Because on the superior surface, I have the peritoneum. So, except over here where there's peritoneum, the adventia is not going to be present. So, adventia is not there. Okay. Now, let's look at the urinary or the urine storage capacity of this. Now, the urine storage capacity, like I said, it's like a balloon. So it's going to be very distensible, or it's going to be very stretchy, right? Now, when it's empty, it's going to have its basic pyramidal shape, right? And it's going to have certain folds. But in general, the bladder can stretch a lot in order to do what? In order to store the urine. So when it's empty, it's going to be like a deflated balloon with its thick walls, right? And when it fills, what happens to it? It becomes pear-shaped. So when you have a balloon that's filled, you're going to realize that it looks like a pear, and it rises above an important region called the pubic symphysis. Okay, so about the urinary bladder, your book mentions a test called the pilogram, which I did not include over here, but basically the pilogram is like going to show you the urinary bladder and the ureters. When you add a special X-ray agent or an X-ray dye, you're going to then be able to see through the through this pilogram. So the test, or basically the thing, is called a pilogram, which will basically show you these things when you the urinary bladder as well as the ureters when you're going to add the dye. Okay, so now let's move on to the urethra. Okay, so the urethra is basically the main function of the urethra. So let's first try to describe the structure of the urethra. Urethra is going to be thin-walled, right? And it is going to carry urine from where? From the bladder to the outside. So now you guys understand, right? So to the bladder, who bought the urine from the kidneys? The ureters, right? From the kidney. And then the bladder held the urine for a small amount of time, and then this urine will be going through the urethra out towards the outside, right? And this is basically going to be by like I mentioned before, this word peristalsis. Peristalsis, which is basically the movement of urine, right? Through like how we're describing it. Okay. Now, urethra. Where is the urethra? It basically extends from the neck of the urinary bladder to the exterior body, like we just mentioned, and there will be different lengths and different functions, right? So in male and female, the urethra is something that is different. It's really, really, really important to realize this part. Okay, so the purpose of urethra, yes, it's to release urine to the outside of the body. But in males and females, it also has other different functions. In male urethra, the urethra is going to be longer. So if you look at this diagram, this is the male and this is the female. Okay, so we're looking at the urethra. The urethra in the males is definitely much longer than females, and it's going to be able to transport something important. It's going to be able to transport semen as well as the urine, which is the general function. It will transport something called semen. Okay? Okay, so now for the urethra, when we are going to be releasing the urine, it's going to be like this, right? This urine is controlled by two important, or the release of this urine is going to be controlled by two important things. What are they? They are going to be the internal urethral sphincter, which can be seen over here, okay, which is above the prostate. So this is my prostate in the males, okay, not in the females. In the males, above the prostate is the internal urethral sphincter. In the females, it's over here. So you can probably say at the base of the trigone. Trigone is of what? Of the bladder, right? So at this area, you're going to be finding the internal urethral sphincter. Okay, and then you're going to have the external urethral sphincter, which is also very important. Now, an important point of differentiation is that the external urethral sphincter is going to be voluntary, whereas the internal is going to be involuntary. How are you going to remember this? You're going to remember this by internal, so it's going to be involuntary. Okay, so internal, involuntary. And external is going to be the other thing, which is voluntary. Okay, so now let's move to the next part. Like, this part to me is really easy. It's about micturition. What's micturition by its name? It's going to be to urinate, right? So it's going to be voiding or the urination, the process, right? So it's basically the act of emptying emptying the urinary bladder, right? Okay, so in micturition, it's really important to know that you have 3 conditions for it to occur. Now let's go over the 3 conditions. The first condition is going to be the contraction of the detrusor muscle. Okay, so the detrusor, remember, it was the smooth muscle. Where was it? It was lining the wall of the bladder, right? And when this muscle, look, the bladder was storing the urine and we had the detrusor surrounding it. When this muscle contracts, what happens? It squeezes the bladder, right? Causing it to what? Causing it to expel the urine or take the urine outwards, right? Okay. Next thing is going to be the internal urethral sphincter. What must happen to it? It must open, okay? So the internal urethral sphincter, remember, it's the ring of smooth muscle or the thickening of the detrusor, basically, which we said was at the junction of the bladder and the urethra, and it basically must contract, or sorry, not contract, but it must open in order to, allow the urine to go from the bladder to the urethra. Okay, next thing we have is the external urethral sphincter. So what must happen to it? It must also open, right? So can we say in general, for urination to occur, both the sphincters must open? Yes, both the sphincters must open. Okay, so the external urethral sphincter is basically going to be a voluntary muscle, right, that will surround the urethra, and when it opens, it will allow the urine to pass to the outside of the body. Okay, so all of these actions together are going to allow the urination process. So for the urination process, first thing is the urinary bladder. Let's start with this area, okay? I think the doctor told you to go from top to bottom, but personally, this is how it works for me. So I have the urinary bladder over here, and the urinary bladder is filled with urine. What would happen to the walls? The walls are gonna stretch, right? So in this area, we have something called afferent receptors, right? So these are going to send impulses from these stretch receptors that, okay, this has stretched to the brain. And what would happen? A simple spinal reflex is going to happen, where the parasympathetic activity in the spinal cord basically is going to be increased and the sympathetic activity is going to be decreased. Why would the parasympathetic activity increase just because I've stretched the wall of the urinary bladder? Because when you have an increase in the parasympathetic activity, the person is relaxed, and urination process occurs when a person is relaxed, right? Not when a person has high amount of sympathetic activity, right? This is the fight or flight. So you need the person to be relaxed. You need to increase this in order to in order to release the urine, and we're trying to do everything we can for that to happen. Okay, so when you increase the parasympathetic activity, the detrusor muscle is going to contract, which will open whom? The involuntary urethral sphincter. And this is the first step of for the urination, which is the opening of the internal urethral sphincter. Okay, then let's look at what we have. So these afferent impulses can also, affect over here. like I said, the higher brain centers are now going to allow or inhibit this process as appropriate. Of course, it's not always going to allow it or not always going to inhibit it, right? So when a person is relaxed, you have the pontine micturition centers. And when you're not relaxed, where are you going to go for? The pontine storage center. So not relaxed, you want to store, okay? Relaxed, you want the center to be the micturition center, okay? Now, the pontine micturition center is going to do what? It's going to act on all of these things. So not only will it increase the parasympathetic and decrease the sympathetic, but also it would decrease the somatic motor nerve activity, right? And in this case, when you decrease this, what happens? The external urethral sphincter is going to open. Okay, so the external urethral, when it opens, it fulfills the second thing that we said for the micturition process to occur, right? So we said three things. The detrusor contracts, which it did contract over here, so that was the first thing. Then we talked about how the internal sphincter must be open. It opened, okay? And what was the third thing? The external must open, and it opened. And so micturition happened, okay? So these were all activating factors, right? So the first thing was the stretch receptors, and the second thing was the pontine micturition center, which basically played a key role in the three conditions to occur. Now, this is how we do the positive. What about the negative when we don't want it to happen? What do we do? Okay, so we are going to rely on the pontine storage center. What does it do? It is going to act on all three of the spinal efferent the efferents, okay? So it would decrease the parasympathetic, increase the sympathetic, and increase the somatic motor nerve activity. So basically, it would do the opposite of what the pontine center did. It would basically just change this. So decrease the parasympathetic. When you decrease the parasympathetic, you're not making the person relax. You're not opening the internal urethral sphincters. When you're going to increase the sympathetic, again, you're going to have a negative effect over here, right? And when you're going to increase the somatic motor nerve activity, what happens? The external urethral sphincters are going to close, right? They're going to close. Okay, all of this together would inhibit the process of micturition. Okay, so I'm gonna explain this part over here in case anyone got confused, because I realized that I did not explain why decreased somatic motor activity would actually open the external urethral sphincters. Okay, so remember, the external urethral sphincters were voluntary, right? So because they were voluntary, they were skeletal, right? Okay, so basically what happens is that the external sphincter is basically under somatic control, which is this one that we just talked about. And that basically means that it's going to get signals from the brain via this system, right? So when the activity of this system is going to decrease, what happens? The external sphincter is going to be, the signals to it would be reduced, and the external sphincter is going to relax. Remember, for the process of micturition, I always need the person to be relaxed. So when you decrease the motor activity over here, this external sphincter is going to relax and allow for the urination to occur. Now, why am I saying when you decrease? Because if you increase the somatic activity, let's say I've increased this activity, the somatic motor activity, what would it do to the external urethral sphincters? It's basically allowing them to contract. When you increase the activity, you allow them to contract. And when you contract them, you're basically going to, you're going to narrow, or you're going to hinder the movement of urine, because you're going to narrow the opening, right? So where is it? Okay, so if you look at it, if you're going to allow it to contract, it's going to narrow this opening, so the urine is not going to be able to pass as easily, right? So it's going to prevent it from happening. This is why I do not need the somatic motor activity. I need it to be decreased in order for this to be relaxed or to open. Okay, now let's move on to the to some things mentioned. I have urinary incontinence. What is urinary incontinence, or who does it basically occur in adults? And it's typically in adults, it's going to be caused by either you have weak pelvic muscles, so you either have weak pelvic muscles, okay, or it could be caused by physical pressure during pregnancy, so during the childbirth. okay? And some nervous system problems can also cause urinary incontinence, okay? Urinary incontinence, it's really easy. Like, urinary incontinence is basically the person is not able, right? So incontinence from the word itself, inability to do the voluntary control of whom? Of the external sphincter, right? So in this case, in urinary incontinence, what would be affected would be the external sphincter, because you're unable to do voluntary control, right? And it would be common in children. So this is in adults, right? But it would be common in children where, like, for example, like, let's say 2 years old probably, or even younger, because they've not yet learned how to control the voluntary sphincter by themselves. But after the toddler years, it's usually the result of these issues, or it could be emotional problems, or, like I told you, nervous system issues, or because the pelvic muscles are weak. Okay, now we're going to do urinary retention. So urinary retention is the opposite of incontinence, right? So incontinence, the opposite of this is retention. So in this condition, the bladder is unable to bring out the urine. Retention, so you're keeping the thing right? So the bladder is unable to expel the urine because retention of the urine, okay? And here, it's sometimes after surgery, in which the general anesthesia that has been given, and for the smooth muscle, it takes it time to regain its activity, right? So remember the detrusor, right? So sometimes when you give anesthesia, it takes time for the detrusor to regain its activity and actually, contract and push the urine out. So in this case, you have urinary retention. Okay, urinary retention, it's important to know that in elderly men, okay, it's related to elderly men. Know the key features and what's happening in each of them, okay? In elderly men, you might have, like, for example, enlargement or hyperplasia of the prostate gland. Can you see? This is the prostate gland, right? So if you have hyperplasia of this prostate gland, it basically is surrounding the neck of the bladder. So if you're going to cause hyperplasia means increase in the size, right? What would happen? It would compress over here, and because it's surrounding the neck of the bladder, it would compress and it would block the urine from coming out of the neck of the bladder, right? And in this case, you're going to have retention of that urine in the bladder, or the urine is kept in the bladder. Okay, how would you treat this? You can insert a catheter, which is basically this flexible tube that you can insert into the person, and it would be allowing the drainage of urine and prevent the bladder from excessive trauma. Okay, and then we have the stress. Okay, since we talked about low urinary output, I want to mention two important vocabulary words. So we have oliguria, okay, and we have anuria. Okay, oliguria or oliguria. Oligo itself means less, right? So this is the urinary output is basically between 100 to 400, okay, ml per day, okay? And in anuria, it's less than 100, which is like really less, right? And anuria, the word an usually means, like, for example, absence of. So you can think of it like this, but there is some urine, so it's less than 100 ml per day. Okay, so this is oliguria, which is an abnormal low urinary output, and it usually would indicate that the glomerular blood pressure is either low, so either low glomerular blood pressure, or it would indicate what? It would indicate, so if you know that in a question there is low glomerular blood pressure, that would indicate what? That it's too low to cause any filtration, right? So because it's too low to cause any filtration, you're going to have a very low urine output, okay? And as for anuria, it could be from, for example, transfusion reactions or any inflammation or, any injury. So any injury could result in anuria, okay? And these are causes, and this is what happens in oligo and anuria. So the most common causes, and the urinary output that you're supposed to know. Okay, Now the last part is developmental aspects. This part was cancelled for our batch, but you have to read over it and you have to understand it. So understand like the basic parts and the most important parts. So firstly, you have three sets of kidneys. You have the pronephric, pro means before, and mesonephric, nephric just means kidney. So pronephric, mesonephric, and metanephric kidneys. Okay, and they develop from the intermediate mesoderm. To be very honest, like I think barely the developmental aspects would be tested, but if they are tested, usually they care about the age more, like what happens when you go like severely over age or when you're a child. Anyways, let's go over it. So you have common abnormalities like the horseshoe kidney. The horseshoe kidney was mentioned in one of the homeostatic imbalances, where the kidneys are basically like a U-shaped horseshoe. So if you've looked at a horseshoe before, you can see that it looks just like it, and the kidneys are very close together in this case. So this would be, for example, because of this is going to result in obstructed drainage. So when the kidneys are very close together, it would result in the obstructed drainage, and it could be because of kidney infections or increase the risk of kidney infections. Okay, but usually it's going to be asymptomatic. However, like these things can happen. Okay, then you have hydrospodias. Again, it's usually in the male infants only, and in this case, it occurs when the urethral orifice is basically located in the ventral surface of the penis. Okay, then I have polycystic kidney disease. The polycystic kidney disease is basically cysts or fluid-filled cysts which occur in the kidneys. Okay. And toilet training usually occurs begins at 24 months of age. So like I said before that, what could happen? You could have urinary incontinence. Okay, and the most common urinary system problems are bacterial infections, which can also lead to UTIs, which is urinary tract infections, basically. Okay, and with age, what happens? The nephrons are lost. So these are things that you might be tested on. So with age, the nephrons are going to be lost, and the filtration rate would decrease, which is common sense. Like the filtration rate would decrease, right? And also, the bladder capacity and tone are going to decrease with age, which would lead to frequent micturition problems and, like I said before, incontinence of urine. And urinary retention is a common problem of elderly men, which we already mentioned over here. Okay, so that's it for the urinary chapter, and thank you for your time and good luck everyone. Don't worry, do not stress out about the Bio 2 exam. It's going to be easy, inshallah. Just make sure that you've studied and go over things again and again and again, and try to do as many practice questions as you can. You're not doing them to expect what's coming in the exam, but you're doing them for yourself to test your knowledge, because just knowing the book material and going into the exam is not correct. This is not Bio 1. They're not going to test you by just the sentence in the book. They want you to apply the sentence, right? So it's going to be, sometimes you're going to get clinical questions, right? Like there's going to be those type of questions. So I expect you guys to do questions before you go into the exam, and you're going to find the exam inshallah, like it's going to be easy and it's doable, of course. And yalla, good luck everyone.